neoadjuvant therapy is the idea of giving upfront medical therapy to a patient before either surgery or radiation. And so when we think about medical therapy with the space of head and neck cancer, you're mostly thinking about, historically, chemotherapy, cisplatin, carboplatin. But in the last decade to a decade and a half, there's been an explosion in the pharmaceutical industry of what we call immunotherapies, which are agents that are also within the medical therapy realm, but are designed to target aspects of the immune system that allow us to prime the immune system to attack cancer. If you think about cancer, it's floating through your body and it's disguised from your immune system. It could be passing right by one of the T cells and the T cell can't tell. And so what immunotherapy does is it basically tags the tumor, and all of a sudden now that cell that was hiding in plain sight is visible. And so the immune system is able to attack it. And so the idea behind neoadjuvant is to say, if we can mount an immune response, is it possible that you might get some reduction in tumor volume that may then be predictive as to whether they can get lower dose therapy?
We're very excited about what we call neoadjuvant therapy, which is a way that we can treat patients before surgery. And then we can determine how their tumor responds at the time of surgery, and that may guide post-operative care. And we've done a few of these trials, and they've shown very promising results. So we're going to continue along those lines as well.
What sets us apart at UNC within the space of neoadjuvant is our adaptation of neoadjuvant prior to surgery. So upfront chemotherapy prior to chemoradiation therapy is already a well sort of accepted paradigm. Within other surgical disciplines, neoadjuvant therapy exists in the space of neoadjuvant prior to surgery. But in head and neck, it really didn't. And if you look back in our literature 20, 30 years ago, people tried to use induction therapy followed by surgery, and it didn't go well, or induction therapy as a predictive model, but that's because we were limited by doing induction with cisplatin. We had limited agents to work with. I think what sets us apart is that we have probably the most experience in the world with duration of how this is done. We have 2 studies that we've completed, one with mature 5-year results. And so we have an understanding of not only what spaces does it work within. We've used it in like the transoral surgery world. We've used it in the advanced smoking and drinking population. And so I think our volume of experience can inform a lot about where can we take this next. And on top of that, not only were we the first in the country really to look at this neoadjuvant surgery model, but now we have great science at UNC with circulating tumor DNA that was established here, with some of the stuff that Dr. Yarbrough is doing, looking at different aspects of our tumor genome and then targeting those molecular markers. And so I see the advancement in this world being, take some of the biomarkers that we have here in Del Yarbrough's lab, take the circulating tumor DNA that we know about, start looking at, can we have predictive markers, give neoadjuvant, evaluate those predictive markers, and then take it to the next level of, let's even further minimize the morbidity we give to patients. We all want to cure patients, but I want to cure patients, especially younger patients, but all patients, and then have them have a life that's worthwhile living afterwards, because it does nobody any service if we cure them and then we don't give them a life that's worth living afterwards.